Uh, as introducing me at the beginning of the conference, my name is Dr. Chang P1. I'm from South Korea. I heard that the impressive introduction and the lecture previously. I arrived in India on Friday night, and I gave a lecture in Hyderabad, and then came to Bangalore yesterday night. I'm very glad to see you, and I have an opportunity to share my knowledge and experience about implant dentistry with you. And thank you for the Academy, KMD, and Dentium Company, which invited me. Maybe the Academy gave me the longest lecture time because came from the farthest country. Thank you. I hope that my lecture is helpful for you. The title is Bone Regeneration by GBL and Bone Graft. Is it predictable? Let's start. I often hear from my fellow dentists or the speakers at the seminars that regenerated bone will eventually resorb away, so that implant fixtures must be placed on the native bone. This implies that the implant fixtures must be placed on patient original bone because regenerated bone by bone graft or GBL procedure will continue to resorb with time. What is your opinion? Is this always true? Is regenerated bone not predictable compared with the native bone? I prepared today's lecture to go through this question and find the answer with you all. To do so, I will present my clinical cases that can show the well-maintenance of the regenerated bone and introduce articles that studied long-term follow-up results of bone regeneration procedure. Let's see some cases showing follow-up results of regenerated bone. This patient, the quality of X-ray is not good because it is very old panorama before over 10 years ago. This patient is middle of 60s-year-old female. Through this panorama, we know that the oral condition of this patient was very poor. There were many teeth lost, and periodontal state of remaining teeth was very poor. Let's focus on the lower left area. In the intraoral photos, we can see that the width of the edentulous ridge was insufficient to place implants. And in the panorama, the height of the ridge was also not enough. The distance from the ridge crest to the inferior alveolar nerve canal was about 8 millimeters. In this situation, we can place short implants such as 5 millimeter length, but I plan to place 8 millimeter length implants after vertical ridge augmentation. This first premolar had distal bone loss and had mobility. So I plan to extract this tooth and place implants immediately. Let's see the procedure. I extracted this first premolar and placed an implant immediately. And I performed the ridge augmentation with bone graft and barrier membrane coverage. I perforated the cortical bone for blood supply and harvested the autogenous bone core from buccal shelf area with trephine drill. I crushed the harvested bone into particles and mixed with particulate bone substitute material for supplement the amount of bone graft. I used titanium reinforced membrane for space making with screw fixation and sutured surgical wound without tension. I placed implants on the augmented site 6 months after ridge augmentation. These CT scan of the augmented site just before implant placement. This is the original crest of the ridge, and this is the augmented area. The alveolar bone height is over 10 millimeter, so 8 millimeter length implants could be placed. As you can see, the ridge width was sufficient for implant placement. In this photo, there was buccal bone and lingual bones around the implants. During second surgery, apically positioned flap was performed for increasing the attached gingiva. Final prosthesis was delivered. These panoramas for follow-up check after the implant placement. This X-ray was taken at the day of implant placement. There was a radiolucent area at the ridge crest. This area was the augmented bone, so I was very worried about that the augmented bone would resorb after loading. However, the radial density of the crestal area was increased as time goes on, and the crestal bone level is maintained for over 9 years after loading. These are the magnified pictures of the panoramas. The radial density was increased. It means that the regenerated bone can function as supporting implants. The prosthesis of number 36 and 37 was changed during this period because the opposite teeth were extracted and changed the upper RPD. But the crestal bone level is not changed, well maintained. Let's take a look at another case. This is upper molar case. This patient was early 60s-year-old male patient. In the panorama, there was severe alveolar bone loss on both posterior teeth. They were hopeless. I planned to extract these teeth and place implants. This panorama was taken 2 months after the extraction. As you can see, there was severe vertical bone loss at the extraction site. We can also see the vertically collapsed ridge in the intraoral photos. I plan to perform ridge augmentation first and then implant placement later. We call this a staged approach. These photos show the procedure of vertical ridge augmentation. I grafted particulate bone and cover it with titanium mesh and collagen membrane. Mixture of autogenous bone and xenograft was used. Although tried to reduce the tension of flap while suturing, wound opening was occurred because of large amount of augmentation. Slightly exposed portion of the titanium mesh was removed with high-speed burr and sutured. The secondary wound healing was occurred at the exposed area. At 6 months after the augmentation, I performed re-entry, removed the titanium mesh, and placed implants. Later, I performed the second surgery and then delivered the prosthesis. These photos shows the change of ridge height during treatment. This is the initial photo. Middle one is after ridge augmentation, and the right one is after prosthesis delivery. We can see that the vertical resorbed ridge was well augmented. These are panoramas during treatment. 2 months after extraction, right after augmentation, you can see the fixation screw and titanium mesh. And after second surgery, as you can see, I performed sinus bone graft by crestal approach during implant placement. at the time of prosthesis delivery and follow-up X-ray. These are intraoral standard X-rays after prosthesis delivery. Loading was started in 2010, 1 year, 5 year, 7 years were follow-up after loading. The crestal bone level is well maintained. Let me show you one more case. This time, it's upper anterior case. This patient was middle 40s-year-old male patient. The periodontal state was very poor. We will focus on upper anterior tooth. This tooth was elongated and labial version, very poor state. I extracted number 21, 22 because of the severe bone loss. This intraoral photo was taken at the day of extraction. The buccal and palatal bone plates were completely destructed when I checked them with periodontal probe right after extraction. 2 months after extraction, this CT was taken. We can see the complete loss of buccal and palatal bone plate on number 21, 22. Fortunately, the bone level of the adjacent teeth was not bad, so I planned the vertical augmentation first and then placed implants. I waited for 2 months after extraction for soft tissue healing. After incision and flap reflection, we could see the huge vertical bone defect. In this case, I harvested the autogenous bone at the mandibular ramus with trephine drill and crushed bone into particle like this. I used the bone substitute to increase the amount bone graft. This particle is bone substitute. This particle is crushed autogenous bone. I grafted bone at the defected site and covered it with titanium reinforced membrane. Labial flap was coronally advanced and sutured. Surgical wound was healed uneventfully. The temporary crown were made with denture teeth and wire splint because I didn't want to press the grafted site with removable temporary denture. After 4 months after augmentation surgery, the membrane was exposed at this point, a small point. To prevent the infection spreading, I removed the membrane. I placed implants after 6 months from the augmentation surgery. I grafted the alloplastic bone on labial side to increase the rich volume during implant placement. The prosthesis was delivered after 4 months from the implant placement. Upper photos show the initial state before treatment. Lower photos shows the finished state of treatment. And these photos show the state of 6 years follow-up after loading. These CT images showed the initial state, and these were the CT images taken at 6 years after loading. The ridge was vertically augmented, and the crestal, buccal, and palatal bone was well maintained for 6 years. These panorama views during treatment and follow-up. Before augmentation, the day of augmentation surgery, 6 months after augmentation, and right before implant placement. Right after process delivery and follow-up. The crestal bone level is well maintained during 6 years after loading. The intraoral standard film shows the stability of the crestal bone. Until now, I presented cases showing the regenerated bone could be stably maintained for 6 to 9 years. These cases are GBL procedures with bone graft for bone regeneration. What is the GBL? As you know, GBL is guided bone regeneration. This is bone regeneration procedure using barrier membrane. What is the function of barrier membrane? Using barrier membrane, bone regeneration is guided by preventing soft tissue ingrowth into the bone defect site. This is the osteopromotion principle. The GBL procedure is usually performed along with bone graft. Here is the ridge with bone defect. After implant placement, the surface of implant is exposed. Then, bone grafting. Bone graft materials function with osteoinduction, conduction, and space maintenance. And barrier membranes function with cell occlusion, block the soft tissue, and wound stabilization under the membrane. Finally, blood supply provides the progenitor cell to make new bone. It is very important. At the beginning, I presented some cases to show the stability of regenerated bone by GBL. Not only my personal clinical experience, but also many other studies show long-term outcome of GBL procedure. Among many studies, the study by Jitzman is well controlled and has the longest follow-up period. The period is 12 to 14 years. At first, Jitzman reported the result of GBL on 1997. In 2001, he reported the result of 5 years follow-up. And in 2013, 12 to 14 years follow-up results were reported. In the first report, 72 patients, 265 implants were included in the study, but during follow-up, some patients were dropped out. As a result, 8 patients, 222 implants were follow-up. In this study, 3 groups were compared. The group without GBL, because not necessary to GBL. Another group is GBL with collagen membrane, and the other is GBL with EPTFE membrane. Implant survival rate and bone level around implants were not significantly different among groups for follow-up period. Not significantly different. Membrane group means implants placed in regenerated bone by GBL procedure. And no GBL group means implants placed in native bone without the GBL. Regenerated bone eventually resorbs away with time. It's not correct. The regenerated bone can be well maintained for long period of time. Implant must be placed in the native bone. This phrase is half correct and half wrong. If possible, of course, we should try to place implants in the native bone. However, we'd better try to perform bone regeneration if we have to abandon clinically acceptable implant position and angulation to place implants in the native bone. Actually, we can often face various bone defects that preclude from placing implant in correct position and angulation during implant surgery. Carlo Tinti suggested the classification of bone defects from the clinical point of view. He classified bone defects into 5 categories, from extraction wound to vertical ridge deficiencies. This classification is made by healing potential of bone defects. The healing potential of the defect at the upper portion of the list is higher than the defect at the lower portion. Number 2, 3, 4 are resulted from narrow width of the edentulous ridge. Today, I will focus these 3 kinds of defects from narrow ridge width because these defects are commonly faced during implants. These are 3 types of defects resulted from narrow ridge. Fenestration is like this figure. The implant surface is not exposed at the crestal area, but exposed below the crestal area. On the contrary, dehiscence defect, the implant surface is exposed at the crestal area. The third one is horizontal ridge deficiency. Tinti classified this defect apart from dehiscence defect. The shape of horizontal ridge deficiency is same with the dehiscence defect, but the size is different. If implant surface is exposed over 50% of the implant diameter, this defect is classified into horizontal ridge deficiency apart from dehiscence defect. Different surgical approach is necessary to these 2 types of defect. This chart shows recommended treatment methods for each defect. As you can see, GBL can be widely used for horizontal and vertical bone defect. Simultaneous approach is used for small defects such as fenestration or dehiscence, but staged approach is mainly recommended for huge horizontal or vertical defect. Block bone graft and ridge split are also useful treatment methods for bone defect, but today's lecture is focused on GBL procedure. We have a question. What method is the best method for bone regeneration? Review article by Dr. Donos compared the result of GBL, bone graft, and ridge split. It says that various techniques are able to regenerate bone in a horizontal direction, but there is insufficient evidence to indicate which technique could be preferable.